It's always happy to see the really good worldwide experts together with us. And Reda, are you here?
Yes, Murad, I'm ready. I'm ready.
Yes.
Thank you very
Now
much.
we can start together the last session. David Cibula has another meeting also. Maybe it's the best to start with him. What do you think?
Okay. Okay.
David, are you with
Okay.
us?
Thank you, Murad.
I'm with you,
Yeah.
on
Thank
all
you.
dimensions,
Thank you.
Murat. Hi.
Hi,
Yeah.
David.
Hello.
Maybe volume a
Okay,
little bit
Murad.
low, just to inform you. So, dear friends, of course, we discuss a lot on vaccination screening and colposcopy. But I know the main problem of Africa is treatment. And this is what ESGO discussed. We are producing worldwide famous guidelines, but does it work for low middle income countries? And thanks for all of your inputs and to David Cibula that he has first created these resource-stratified treatment guidelines for cervix. And you will hear now what's going on. Reda, any words from you?
Yes. Again, I would like to thank my dear professors, all speakers, and all attendants. I would also to greet all my African colleagues. Actually, it was a dream to have this great project that ISGO prevention project to eliminate cervical cancer in Africa. And this is second webinar, as you know. Africa is the most prevalent area in the world of cervical cancer. So I would like to thank ISGO Prevention again that they work to eliminate cervical cancer in our region. Thank you again within the name of all African people. I would like to start this session with my great professor David Shibula. He will start speak about the ISGO resource-certified treatment guidelines of cervical cancer. Yes, dear professor, the stage is yours.
Thank you, Reda. And I'd like to thank ASCO and all the organizers for this very new initiative. It's a fantastic meeting. I'm very glad to see the friends, Murat and Vesna and others here. And my topic will be just to introduce you a new initiative from ASGO. You probably are aware of ASGO guidelines, which started quite a few years ago, but it became really internationally popular, or it's really very well perceived, and it's used broadly. And the aim of our group was to try to adopt these guidelines for the I don't want to say for low or middle income countries, but for those regions with some limited resources. So first of all, I'd like to say a few words about the rationale, which is, however, very obvious probably from all these previous lectures. So you probably touched many times this paradox of the highest incidence and the highest burden of the disease in the regions with a lot of limitations in the resources, while those vastly used international guidelines are usually developed in the US, NCCN, European guidelines. And there are quite a few new inventions within recent years, such as immunotherapy, image-guided radiotherapy, sentinel lymph nodes, and a need for identification, ICG, or a need for pathological processing by ultrastaging. And all these new inventions are demanding for the resources. So I expect that there are many limitations to use them, but all of them are already implemented in the international guidelines. So can you move the slide for me? Because
Yes.
it seems it does not work for some reason. Thank you.
Try to click on the screen again, please.
This, which I did, and
okay.
Yes.
Let's try
So,
again.
yeah.
Oh, let's try again.
Okay. So before we started with this exercise, ESGO launched a survey, and some of you might be among respondents. So we said it was quite heavy exercise, so thank those who responded. And we received almost 300 responses from 60 countries. And we first wanted to understand what the situation like in different regions in the world. So obviously, especially in these countries of Latin America, Africa, Asia, the exposure to cervical cancer is definitely much, much higher. Those are number of cases per year in institutions of those respondents. At the same time, we were surprised that it was not directly mirrored in the number of radical hysterectomies. And the reason for that is that the majority of patients are in higher stages, which are not eligible for surgical or primary radical surgery. And the proportion of patients in stage 1 is usually very low. Then we also ask for the availability of diagnostic methods, treatment strategies, and obviously the availability is only one of the limitations. But other very important is that in many of those countries, those techniques or methods are available only if it's paid by patients. So it's another limitation because it's then available only for a certain proportion of patients. Not surprisingly, also the access to even surgery, but especially to radiotherapy, has a lot of limitations. So there are different approaches because this was nothing new to try to adopt current guidelines to those limited resource guidelines. One option is just to search, uh, uh, to try to identify the best guidelines fitting to different setting. There's even a guideline for doing such a guideline search. There are ASCO resource-stratified guidelines on cervical cancer published 10 years ago. What they did, they tried to develop recommendations for basic, limited, enhanced, and maximal or optimal situations. So they try to develop a kind of flat settings where everything is basic or everything is limited or enhanced. Also, NCCN guidelines offered a kind of tiered recommendations for core and basic resources by selecting from the list of recommendations those who are considered to be available elsewhere. Our approach at ESGO was slightly different. First, we said that these European guidelines developed by 3 societies, gynae oncology ESGO, radiation oncology ASTRO, and pathology ESP, will be considered as the basic guidelines as in case of optimal setting. Second, some fields will not be covered: screening, vaccination, or specific fields like cancer in pregnancy. Third, our aim will not be to change or adopt or update these original ESGO guidelines only in case of very new evidence and very strong evidence, which was the case in 3 situations: SHAPE trial for radical hysterectomy, A18 immunotherapy for the treatment of locally advanced disease, and Centix and Phoenix trial on sentinel lymph node biopsy in early stages. And there was only one new chapter in these resource-stratified guidelines on HIV infection, which we considered very important for these regions, and which was not included in the original ESGO guidelines. We also tried in our paper to emphasize that it's not only the limitation in the equipment, but there are many sources of limitations. Can be access to care, can be manpower, can be training, can be a lack of experts, can be even cultural barriers. Some techniques or some treatments which are acceptable and standard of care in some regions might not be accepted in different regions, like stomas or exenterations. So at the end, what we wanted to emphasize that it's not guidelines for low middle income countries, but it's supposed to be the guidelines for a resource limited setting, meaning that such limitations can appear anywhere in the world. Even the richest country in the world can have some limitations, can face limitations in manpower, can face limitations in some experts availability. So we wanted to develop guidelines which would be useful and available and can be used in any situation when any of those pieces are limited by the resources. We followed a certain development process, starting with the nomination of multidisciplinary team, and those are members of this international working group. You see that we wanted to have well-represented countries in South America, North Africa, South Africa, Asia, and also Europe. Then we also ask in our survey for identification of limitations. So what can be the limitations in these different settings? And our group then tried to define alternative solutions in case of those limitations. Then we send the first paper for the external review, and we receive almost 200 responses. Then we implemented these comments into the guidelines, and currently we already finished the paper, and the paper is about to be submitted for publication. So just to introduce you the glimpse from the guidelines, how the guidelines look like. So this is an example of diagnostic workup. On the left column, you see the original guidelines. So let's say these are the recommendations in case of optimal setting. Then what kind of limitations can appear? And finally, what are the potential solutions in these individual limitations? So as an example, in a diagnostic workup, if MRI is not available or the access is limited, because MRI is considered in majority or in all international guidelines as the gold standard for local staging of cervical cancer. Our solution is expert ultrasound as available option, which if performed by an expert is an alternative modality with very similar accuracy, and we now have data from retrospective, prospective, multi-center studies. So we already have a very strong evidence that ultrasound is equal to MRI in local staging. And we also wanted to emphasize that CT scan, it should not be considered a suitable alternative for local staging. But many of respondents said, but what if expertise in ultrasound are not available? And the response to that is, expertise or experts are not growing on trees. Experts must be trained. Experts must be educated. But experts can be trained and educated anywhere in the world. So we wanted again to stress that staging should always be available inside treating patients with cervical cancer, because without a proper staging, you cannot treat your patients properly. If you cannot select at the beginning good candidates for surgery, for radiotherapy, for systemic treatment, then you cannot successfully manage patients with cervical cancer. So staging is absolutely a mandatory part of the management. And a lack of expertise should not be an excuse for insufficient clinical staging, because the expertise should be built within the teams dedicating to the management of cervical cancer. So that's one example. Another example is from surgery, surgical management of early stage tumors, sentinel lymph nodes. We implemented a new recommendation based on new data from the Centix and Chinese Phoenix trial. But that excellent biopsy alone without pelvic lymphadenectomy is an adequate staging procedures in tumors below 4 centimeters. But then, if what to do if SLN is not available because of the absence of technique for SLN mapping? And the potential solution is that if ICG is not available, it should not be a barrier against SLN biopsy, because blue dye is a cheap technique. It should be available almost everywhere, and blue dye can offer a relatively good detection rate with very high sensitivity. So it's an alternative technique which should be available. But very often, another limitation is a capacity of pathology for ultra staging, because this needs more workload, or requires more workload from pathologists. And the solution is that even if there is a limited capacity by pathologists, there is a good reason why to detect SLN besides doing pelvic lymphadenectomy, and to submit sentinel lymph nodes separately from other pelvic lymph nodes to your pathology, because there is much higher risk that they will detect metastasis from sentinel lymph node if they do more slices, more levels of examination in sentinel lymph node than in any other pelvic lymph nodes. In other words, it made all sense to bargain towards the capacity of pathologists and say, okay, so let's evaluate less pelvic lymph nodes, but rather do more levels on sentinel lymph node. It makes much more sense and can improve your accuracy of surgical staging. So this is already my final slide. I'd like to once again thank this wonderful international working group, which we together developed these resource stratified guidelines. I hope that it's going to be published soon, and I very much hope that you will find them useful for your clinical practice, and it will find their place and improve the management of cervical cancer internationally. Thank you for your attention.
Thank you so much, David. Reda, are you also here? I
Okay,
think,
thank you, my dear professor, for your excellent presentation.
yeah,
Now, and also Professor David have some work now. So, if you have any question, please we can start question to Professor David now before he leave.
yeah. If there are any
Is there any
questions,
questions?
please write. David, a few
Okay,
questions.
thank you.
No, Reda, a few questions. Do you think the
Yeah.
guys, I
No.
mean the population here today also asked for a resource stratified guideline on prevention, the screening registry, and vaccination also, of course. I mean colposcopic management, because a different setting we are talking, no infrastructure, which similar problems for vaccines. Uh, Maybe you can join us, but this is also very important for us, to implement the preventive measure in a resource stratified manner. And another question for you is the sentinel lymph node. Uh, do you think that technically it is really possible to develop uh, experienced pathologists for this?
Yeah, thank you, Murat. So first of all, yes, definitely, for the countries which we speak about, it's probably much more important to have good guidelines on screening and prevention than on the treatment. And it's gonna be much bigger challenge because our situation was relatively easy because we simply took ESGO guidelines as the basis, and then we just adopt them. So it's definitely, very good initiative, but not easy. The second question on SLN and the pathology, I try to explain it. The main objective or main philosophy that we tend to remove, historically, I remember, and you definitely would remember as well, when we were lecturing 10 years ago, and the better was the surgeon with the higher number of lymph nodes. So if I had 15 and you had
Exactly.
12, then I was better surgeon than you. So there was the quality indicator for surgical staging was in quantity, in the number of lymph nodes, and then the pathologists, receive a bunch of tissue, which is a mixture of lymph nodes and fatty tissue, and they have to, find the lymph nodes first, and then they have to cut each lymph node, at least some of lymph nodes, and which one. Uh, because after systematic pelvic lymphadenectomy, you have between 20 to 30 lymph nodes, so it's a lot of work. Instead, the main advantage of sentinel lymph node is that we as surgeons identify the lymph nodes, which are very few, with the highest risk of metastatic involvement. And and there are very good data on it, that we find in sentinel lymph nodes more metastasis with, more levels. And there is nothing like as standardized protocol for ultra staging. So what I say for pathologists, instead of evaluating 20 lymph nodes from the pelvis, it's better to focus on 2 sentinel lymph nodes and do 5 levels or 4 levels from each of them, because your probability to find mets in these other levels is much, much higher than to find metastasis in any other pelvic lymph node. So I would say, especially if your pathologists are limited with the workload or with their capacity, even it's even better for them if you send them sentinel lymph nodes, because you send them 2 or 3 lymph nodes and you will say, please try to focus on these 3 instead of assessing the bench of tissue.
Thank you so much, David. You have limited time. Just some people ask also packet guidelines, cell phone applications, but these will be later on. Also, resource-certified guidelines on other cancers will be released, but we need time. Thank you so much, David. Reda, who is our next speaker?
I would like to answer in this next presentation. Will answer the difficult question for treatment of high-grade squamous intraepithelial lesions. It is what is better, ablative or excisional technique in our low resource setting as Africa. I would like to present my dear colleague Maria Carriero for their presentation. The stage is yours, my dear colleague. Yes, Mara.
Thank you for the kind invitation in this conference, and we're going to move to talk about different treatment techniques and which of these would be convenient for African countries. I think it's very important when we treat disease that is not cancer, but
Reda, it's no
to
video.
think of the priorities and how
stage.
important it is
Okay,
that we
it's recorded.
don't
Yes, okay.
over-intervene in people who are young, as the aim of treatment is generally to minimize the risk of recurrence, but also detect and treat disease, but at the same time preserve healthy pregnancy and sexual function. And I think before we talk about different techniques that may be more readily available in Africa, it's important to understand the principles behind treating cervical precancer. I always mention this graph with all the people that are undergoing screening, which is the whole female population of a country. And the aim of screening is to bring it down with a positive HPV test to that small proportion of individuals that have a positive test, then apply different triage and diagnostic tests in order to come down to that smaller part of the population that has CIN, to then come down to that single individual that has high-grade precancer, which is essentially the whole aim of screening, and to treat this in order to prevent cervical cancer that can happen in about 30 to 40% of women with high-grade disease. The principles of treatment is that the whole transformation zone should be treated to a minimum depth of 7 millimeters, whichever the technique is. That all high-grade disease should be treated, but low-grade disease can be monitored until it goes towards the one or the other direction, but of course a lower threshold for treatment in older women. Whilst ablation needs a previous biopsy, it has to have a fully visible squamocolumnar junction, and it has to involve less than 75% of the transformation zone, entirely located in the ectocervix, with no involvement of the vagina or the endocervix, no evidence of cancer, no pregnancy, and the patient should not be menstruating. There are the transformation zones in different types, and what you do is significantly affected by whether you can fully see the transformation zone, and that determines the sort of type of excisions as those have been defined by the International Federation of Colposcopy and Cervical Pathology, with the aim to offer type 1, 2 and 3 excisions to ensure that you treat the disease and that you also reach the crypts that are present in the endocervix. So when we try to choose some treatment, the priorities are different. They depend on the person's age, fertility wishes, the size of the lesion, the transformation zone, the quadrants, the severity of the disease, and of course we take into account the risk of invasion, recurrence, and the reproductive outcomes with premature birth and second trimester loss. And there are many different excisional and ablative treatments that you can see in the slide. The loop has become the most popular because it's easy to use, it's easy to learn, it's low cost and maintenance, it provides you the histological sample that rules out invasion, glandular disease, and also gives you information on the margins. However, when Mark Arbin looked at the value of the margins in individuals that were being treated, he found actually that the margins were predictive of recurrence, but actually that the presence or not of a high-risk HPV positive test at 6 months was more predictive than the margins in terms of predicting women that will have high-grade disease. In, of course, the case of excision, there's always a risk of missing glandular disease or invasive disease. And if you look at the data that has been published to date, 0.29% of women that had a loop excision for CIN ended up having a squamous cell carcinoma or an adenocarcinoma. In another series, this was higher at 7.2%, which I think is a bit higher than what we normally see. So it has to do with the location and the quality of the cytology, of course, in the study. And in one of the studies by a British group, you can see that the risk was 1.9 for cancer, 1.9%, and 1.3 for CGIN. And when we looked at our own audit data at St. Mary's Hospital, at Imperial, we had 0.98% of cancer in women who were treated for high-grade CIN and 0.8% CGIN in those people that were also thought to be treated for high-grade CIN, which will have been lost. Of course, it's important to note that 83% of those cases were actually stage 1A1 disease, and the referral indications were actually quite different between the different groups. So why did ablation suddenly come back into fashion, at least in some countries of the Western world, when it was previously abandoned due to the availability of the excisional treatments? And I think there was a tendency to go back to ablation in some selected cases because of this meta-analysis in the Lancet in 2006 and the further meta-analysis in the BMJ in 2008 that suggested that excisional treatments increase the risk but not the ablative treatments. And if you look very closely at the results, you will see that the risk was higher with the most aggressive forms of treatment. However, a few years later, when this data was reanalyzed, but this time with higher number of studies, it was found that actually even ablative treatments increased the risk, although the increase in risk was lower than that of the excisional treatments. The fact is that what determines the risk is the cone length, and the different characteristics of the technique affect the amount of cervix that you remove. However, when we looked at the loop excisions that are less than 10 millimeters as compared to women that have CIN but have not been treated, there were only 3 studies, so it is questionable whether there is actually an increase in the risk in loop excision in those individuals. And if you think about it, most women having ablation would not require a loop excision that is more than 10 millimeters, because by definition, to be eligible for ablation, they should have a visible transformation zone, no suspicion of invasion, and no lesion that extends in the endocervical canal. So there are selected low-risk cases that are likely to do very well. The fact is, however, that based on these findings, there's been a decrease in the radicality of treatment and the cone length, and at the same time, a decrease in the risk of preterm birth in those individuals. People have learned from the risk of premature birth, and they have become more conservative in selecting who to treat, which was a success, but also more conservative to remove less healthy tissue with excision. But it's very important to be cautious about this and not go to the complete other dimension, because if you look at the data that records whether the different treatment techniques are equally efficacious in terms of recurrence, you can see immediately that the evidence that we've had until now is quite limited. There are 3 studies, for example, just in the randomized trials in the Cochrane review comparing CKC to LEDs, and it's a study that is grossly underpowered to show differences. And of course, when we have absence of evidence, it does not mean that there is evidence that there is no difference. But are they really the same? And the answer to this is that we have increasing evidence over the last few years that this may not be the case. It appears that excisional treatments have better outcomes in terms of margins, in terms of risk of treatment failure, when compared to less aggressive excisional treatments. And if you look at the data of invasive cancer, there seems to have been increasing after treatment over the last few decades, probably as a reflection of the fact that we do less hysterectomy, so more women have a cervix, but also a reflection of the fact that we do less radical excisions. But I think it was very important to prove this point because people have become increasingly conservative, and I think this is why we performed the network meta-analysis, exactly to look at this trade-off between effectiveness and reproductive morbidity, balancing those risks for those individuals and trying to get all the literature, including both randomized as well as observational data. And by doing these networks, we have proven what we suspected, that actually the risk of preterm birth increases with more radical treatments, but the actual risk of recurrence decreases. And it was the first time that this was actually shown, as until now it was thought that you can save premature birth, but all treatments are equally effective. And if you see this killing plot that actually talks about absolute risks, and you can see the risk of treatment failure, high-grade treatment failure, and premature birth immediately with absolute risks, which is essentially what we quote to patients, and for us it's easy to interpret them relative risks. You can see immediately that the inverse relation, and those figures are those that we should quote to patient, because a relative risk of 2 in some risk that is 1 in 100,000, it just means that this becomes 2 in 100,000, but it's still a very low risk, and that's why absolute data is very useful. And if you look at this data on the long-term recurrence from the same network meta-analysis, you can see that the data is showing an increased risk for ablative treatments, cryotherapy, laser ablation, cold coagulation, and it increases every sort of grade of CIN and CIN3 only. And I think it's very important to keep this in mind. When we tried to look at the risk of invasive cancer for excision or ablation, there was no clear evidence of an increase, but actually the data was very limited and there was no discrimination between the different treatment techniques. In terms of cost and effectiveness, by balancing the amount of recurrences, premature birth, how much you need to follow up those individuals, it was concluded that actually loop excision provided the best balance between the two. The question, I guess, for this audience is also whether the balance is the same for low and middle income countries. They have different screening methods, cytology, VIA, high-risk HPV. There are different screen and treat algorithms because of compliance, distance from the different health institutions, the equipment and availability, the weight, the transport, the availability of electricity is different. And of course, the need for trained healthcare professionals to increase accessibility may not be available in all settings. This brings us back to the known cancer divide and the global chasm, which reflects this inequity in the access of all components of cancer care, control, and prevention. And it is important that when we talk about all of this evidence, which is important to know, to bring now all of this evidence and embrace the inherent differences that exist between the high-income countries, where more centralization, high-quality surgery and diagnosis is very important, when actually in the low and middle income countries, the access to facilities may be the priority. You can see here an image of ablative treatments that are quite popular in those countries, with laser ablation. When it was introduced, the precision, which is probably not something that could be used in any of those settings because of the disadvantage of high expense and maintenance of the equipment, and the cheaper versions of cryotherapy, cold coagulation, that is cheap, effective, simple to use, without any abnormalities, without any complexities. The cryotherapy, which is very commonly used in those settings, is a safe procedure. It does use an ice ball to actually burn the cells and cause necrosis. And it is important to freeze for 3 minutes, thaw, wait for 5 minutes, and then freeze again for 3 minutes. It is not a treatment that is recommended in the Western societies in people with high-grade disease, because it has been shown to have higher recurrence rates, but it is an easy, low-cost equipment that could be used. The alternative includes the cold coagulation, which is really a funny name, because actually it's thermal ablation, which is a probe that is heated at 100 to 120 degrees, and it has 1 to 5 overlapping applications, and most of the lesions will require 1 to 2 of this. And it's very easy to clean and wipe the probe with cool water, wipe it dry, hit it again at 120, and it is ready for reuse, and this makes it a very successful treatment in those settings. There have been results from India about the rates of cure that you see for both cryotherapy and thermal ablation in this slide, and also data from a group in the UK and Scotland, in Dundee, where they've used this in individuals, and they've shown equally good results for those individuals that had cold coagulation, of course, with the awareness that those are the low-risk cases, so they're deemed to have some selection bias in terms of being chosen appropriate for an ablative technique. The follow-up after treatment should include HPV testing, cytology via or V-like colposcopy, biopsies of the abnormal areas, and repeat treatment if there are recurrent and residual lesions. And I think there are some WHO guidelines for the use of thermal ablation for precancer in some of those low and middle income countries. And the recommendation is that if they are screened positive, whatever that screening is, and there is no suspicion of invasion or glandular disease, they are eligible if the transformation zone is fully visible, the lesion is fully visible, and the probe tip can achieve complete ablation of the squamous junction epithelium, reaching the upper transformation zone and the lesion. Women who screen positive are not eligible for ablation if there is a type 3 transformation zone, or we feel that the probe cannot reach the tip of the lesion. There are some further guidelines on how to use thermal ablation for cervical disease, and I think you can see here that this is appropriate together with loops, cryotherapy and thermal ablation for people with CIN2 if they fulfill all the criteria that we have discussed. It also mentions that the ablation should be 20 to 30 seconds for at least a minimum of 100 degrees to offer appropriate treatment, and that you can use as many applications as you need. And it says that loop excision should be available for those people that don't fulfill the criteria, but this can be used in cases where a loop excision is not available, balancing the risks together with alternative treatments. Finally, the WHO recommends that there is no need for prophylactic antibiotics, and that women should be proceeding with a loop excision if they don't fulfill the criteria for ablative techniques. And I think with those in mind, it's important to put all the treatments in context with the settings where you work, and knowing the evidence behind its treatment, seeing the availability and how you can optimize the use of the right treatment or refer women to the place where they can have the right treatment is important. But equally, if you're in a setting that none of this is available, doing a treatment is more important, and accessing that individual is more important than no treatment at all. So as Albert Einstein used to say, it's extremely important to think about the problem, all the characteristics of each location, of each setting, and then a few minutes to see how you can solve the problem after you've considered all the parameters that are important in the decision. Thank you.
Okay, Reda, I think it was a wonderful presentation from Mara Kyrgiou, and this was a hot topic today. Many of the participants asked these questions. One question was that maybe you can answer. I mean, how do you see the safety of ablation for type 3 zone, postmenopausal cervical transformation zone? And there is another question from Mircea Bekele. If what happens if you make a leap and surgical margin positivity? Reda, do you have any comment? I think your internet is not stable, Reda. But I can answer to these questions that, as you can clearly see in the presentation of Mara, there is a risk after ablation of missing some sorts of cancers in the short and long term, definitely. But especially for glandular lesions and for any type of lesion that you see entering into the endocervical canal, if possible, you should prefer excisional treatments. And this is also in accordance with the WHO guidelines. And additionally, for the question of Mircea, there are a lot of data showing that the margin positivity can resolve during follow-up. Because when you make a leap, you use electrocautery, and this energy, produces some damages in the epithelium, and within time, you can have a clear margin. Of course, if the lesion is CIN1, you are in a much more safer place for this strategy to follow up. For me personally, if a patient has a fertility desire, if the cervix is short already and she has a risk in the future for preterm labor, I would definitely suggest the follow-up with colposcopy, HPV, and pap smear. And this follow-up is much more safe for CIN1 lesions, dears. Okay, Reda, the next presentation is a modified leap for African settings. I think this is a new technique that you develop in Egypt. Who will make the presentation? Rafik, are you available? Rafik Barakat?
Yes, I'm here.
So Rafik, will you make the presentation?
I think Dr. Reda should start and then I will follow, but I think he is not connecting with us. Dr. Reda, Dr. Reda.
Reda now drop off.
Yeah, I think, yeah.
So maybe we can go with the next speaker.
Okay, no.
And again, the radiotherapy is Nimat Higazi from Egypt. Is here?
Yeah, hello. I am here.
Hello, Nimat. Hello. Nice to meet you. Can
Nice
you
to meet you
summary
all.
the radiotherapy and chemotherapy facilities?
It is slides are working now. You can see my slides.
Reda, you are back?
Okay.
Yes, please use the slides so then we will listen the modified leap video, okay?
So it's an honor to me to share the presentation with my dear friend. Okay. Slides first, then video at the end. Yeah. It's an honor to share this presentation with my friend Professor Rafi Barakat. Actually, he introduced this modified leap procedure in our locality and spread all over Egypt. So I think with its low cost will be suitable for our African countries. Yeah, slides please. Okay. Now still not moving.
Okay, it is moving, Dr. Reda.
Yes. Not freeze again. Yes. So when I just move the slides. Please, for technical help, can you move the slides?
I think you have finished the presentation.
It is not responding.
Reda, please don't be this fast. Just give it some seconds
You are clicking,
because
Dr. Reda. Yeah, you are clicking frequently.
you can start from the beginning now.
Okay.
Oh.
Yes.
Wait for a little lag.
Yes. Okay. Yes, I will. Yes, my Professor Rafi. Professor
Now try to click into the screen, please.
I think you have some technical problem. Susanna, please, can you move, please?
Reda, just click into the screen and you can click through the slides. Just give it some few seconds. Yeah.
Okay, this is working. Thank you very much. So we'll speak today about modified lead procedure that introduced by my colleague, Professor Rafi Barakat. I will skip these slides that address the magnitude of the cervical cancer burden in Africa. As you know, the treatment modalities for cervical cancer include for CIN follow-up and high-grade squamous intraepithelial lesion, either cryotherapy, LEAP, which is expensive, and we have introduced the modified LEAP procedure. And also, if the patient is old age or have another organic pelvic problem, so we can counsel about simple hysterectomy. The technique of this modified LEAP procedure will be discussed with my friend, Professor about LEAP procedure, Professor Rafi Barakat. Yes, Professor Rafi, you can start.
Okay, thank you, Dr. Reda, and thank you for the invitation. Actually, the main idea about the modification for this LEAP was about three problems. The first one was the availability of the loop in Egypt. Most of the time, it is not available in Egypt. This is number one. Number two, when it is available, the cost for the local patients is high, comparatively high for the locality of our locality. And the third one, that we deal in most of cases with large volume cervix with chronic hypertrophic cervicitis. This was complicated by intraoperative and extraoperative bleeding many times. So we thought about how to solve these problems, and we tried to introduce some modifications. And I think this can, this is the original machine that we have used in the start, 2005 and 2007. And this was the MED thesis of in my university. Then the first case I did by the machine. And as we go with the different cases and with different situations in our country, we found that we have to reduce the relative high cost in the low resource countries in our locality. The intraoperative bleeding, as I mentioned, we deal with chronic hypertrophic cervicitis in most of cases. So the volume of the cervix is large and the bleeding intra and postoperative is considerable. And also to improve the exposure of the part that we excised, aiming to shorten the operative time. So we started to follow these guidance by the WHO. We should consider the poverty that will not end. This was the WHO proposal a few years ago, and the elimination of cervical cancer should depend on ending poverty. I think poverty is increasing all over many countries, especially our locality, and also reduce the inequity among countries. I think now there is more inequity among different countries. So I think we have to proceed with solutions that can overcome this one. Sorry? Sorry. Okay. These are the actual prices from some place about some instruments that we need to use. And you can see that the one patient use may reach $100, something like that. This equals in Egyptian pound about 5,000, which is much higher than the expenses that can the patient go. What are the notifications? Very simply, we secure the cervical angles at the 3 and 9 o'clock by suture ligature, and this aims to reduce the blood loss intra and post-operative. And at the same time, I leave the ligature in order to make a traction on the cervix. This will result in these angular ligatures will improve the exposure very good, as we will see in the video. And instead of the usual standard loop and ball, I will use the spinal needle or stylet as a loop substitute. And I will fix it for the switch pin of the diathermy, which is present in most of our operative rooms, available without added cost for the patient. So first, I will secure the angles. As we see, I use Vicryl or 1, and then I will tract on both angles in order to make the exposure more easy. This will bring the lesion outside towards the operator very easily. So I will take the spinal needle, either the black one or the orange one, according to the volume of the cervix. And this is the pen, the usual pen used in the diatherm. And then I will make a loop by it like this. And then I will fix it, and I will use it as very simply as a loop instead of the loop. I will adjust the amplitude of the diatherm machine according to the tissue that I'm cutting in, according to the volume that I have to remove. So I started to cut from posterior to the anterior, and I cut the cervix on 2 pieces because it was large in volume. And this is the final image. As we see, I'm doing just coagulation by the pen itself. So this is how I will make a loop, very simple procedure. And this is the angle, the ligatures in the angle. It reduced marvelously the blood loss during and post operative bleeding. And this is the bed of the cervical lesion as tailored before. And this is the final image for the case. And we can see very simply, this video will take about 2.5 minutes, and it will explain how I just said. So it is a very simple procedure. Our patients, as you know, come and go. We may not find them in post-operative. So yeah, if excision is indicated, we will move towards excision better than the ablative methods. And by using these instruments, my patient will cost about $3. This equals 150 pounds in Egyptian pounds instead of about 70, 80, or $100 according to the type of the instruments that I use. This is the angular stitch at 3 o'clock. Very simply, I will do simple ligature and surgical ligature, and I then use it as a traction in order to improve the view for the operator and minimize the possibility of thermal injury, if any, during the procedure. So this is 3 o'clock, leave it, and cut the other end. Then at 9 o'clock, I will put another ligature. Marvelous effect for me in my practice. As I said, the large cervical volume, all the time I find a bleeding, a considerable. Of course, I don't need blood transfusion, but comparatively, this make the post-operative very smooth for my patient without spotting and without intraoperative spoiling of the field by the blood loss. This is the lesion which I was planned before by the colposcopy and the VIA test, and then I will bring the spinal needle. This in Egyptian pounds equals about 70 or something like that pounds. This about $1.50 American dollar. Then I will use the usual diatherm machine available in our operative theater, used for many purposes. And then I will start cutting posterior to the anterior. And as I said, in most of cases, I need to cut it in two pieces, in two settings, because the large volume, as you see, of the cervix. Actually, I find most of our patients with this large volumed cervix. So I will take the other half in one cut. So it's only two cuts. And as you see, the bed without considerable bleeding, very minimal bleeding. And this is because of the angular stitch I took at first at 3 and 9 o'clock, using either 0 or 1 vicryl. This will help me a lot. Then I started to coag the bed in order to control the bleeding coming from the cervix. Very simple procedure, very economic for the hospital and for the patient. I now finished, and this is the final appearance of the bed. I think it is very accepted, and according to the pathology of the margins, it's very good, and the depth according to the transformation zone, as we mentioned in the previous lecture. So it is cheap, available, decrease intraoperative bleeding loss, decrease secondary hemorrhage post-operative, and it shortens a lot the operative time. Thank you for your listening, and I hope it was beneficial for the audience. Thank you.
Thank you, Professor Faye, for your kind improvement of the LEAP technique with little cost. I think it is very suitable for our African countries. Yes, Murad, are you okay?
Yes, Reda, I think it will. Some people ask where we can find the video. Do you have any video YouTube channel?
Yes, I can share it. Susanna can share the video. Yes.
Yeah.
Please, Susanna, can you share with others?
To the
Professor, if you don't mind, we can share the video.
Yeah, of course, yeah.
From
Okay,
YouTube link, maybe. Okay.
Yeah.
Excellent.
Okay. Yeah. Thank you.
So let's move to Nemat.
Yes.
Just one question: are you doing this surgery in local anesthesia or general anesthesia?
Both of them.
What?
Both. Sorry.
Are you using general anesthesia or
both
local?
of them? Yeah. According to the compliance of the patient. Yeah. It may be done by local or by general. Yeah.
But general is
but
also...
our patients, they can't compensate for just putting the speculum. Okay, so most of cases I use a spinal or something like that. Better for me.
Okay, but for generally, I don't want to give the wrong message. I mean, of course, the compliance of the patient is important.
Yeah.
But usually LEAP is something that you can only make with the local anesthesia.
Yeah.
We should not make a message that we
But but you can imagine, Murad, that embryo transfer in our patients, they prefer to do it under anesthesia.
Yeah. I mean, if she cannot compensate, it is. But if you look to the data, the embryo transfer,
much better.
And in the whole LEAP, in my institute, it's less than 10% that we use general anesthesia. In a great majority, we make it by the local anesthesia.
Yeah. I do agree. Absolutely, I do agree with you.
Yeah. Okay, let's go to the last speaker, Reda, and talk about a little bit Africa and of course Egypt in chemo and radiotherapy. Nimat, are you here?
Yes, hello. Thank you for invitation me to this important event about how to prevent the cervical cancer in Africa. And now we go to our clinical part, how we treat actually most of the cases we faced here in Egypt with the locally advanced cervical cancer. Unfortunately, most of our patients, she has locally advanced cervical cancer and presented to us as a stage 3, actually 3B or 3C and stage 4A. So we'll go immediately to treatment of cervical cancer in Egypt. So can allow me to control? Yes. As all we know, the incidence of cervical cancer unfortunately increasing in developing country and associated with increased deaths from the cervical cancer. And now it's cervical cancer, the fourth most common cancer in the woman. And so we need a very important to do what is called national registry for all newly diagnosed cases. And recently we have accepted abstract at ESTRO that will be presented in next October in San Francisco about the incidence of human papilloma virus associated with new cases of cervical cancer in Alexandria, and how we unfortunately found most of our cases associated with human papilloma virus infection. As all we know, the human papilloma virus associated with cervical cancer, and we need almost from 10 to 20 years from the instance of infection till appearance of cancer. And unfortunately, we don't have vaccination program till now for all young ladies for against the human papilloma virus. So we need to achieve the goal of WHO to vaccinate at least 90% of our girls with the human papilloma virus vaccine by 15 years of old. And in Egypt, we have Egyptian presidential program for screening of cervical cancer. But till now, we have a barrier for the screening of cervical cancer. Until now, the woman has afraid to go to office to make this screening because of lack of awareness, inadequate lack of sometimes of manpower. So still we have preventable disease, but we still have barrier of the screening for the cervical cancer. We speak about the instance of treatment of cervical cancer. As I said before, most of our patients are locally advanced cervical cancer. So let we speak about the adjuvant chemo and radio. If the patient discovered with the cervical cancer and underwent the surgery, so what is the risk factors that they give for this patient post-operative radio and the chemo? If the patient has positive margin or positive lymph node, will go for concurrent chemo radiation associated with weekly cisplatin. However, if the patient has intermediate risk factor after surgery, like lymphovascular invasion, large tumor size, we give only adjuvant radiotherapy. Why? Because the adjuvant radiotherapy will decrease the incidence of local regional recurrence. We'll go to the huge bulk of our patient, almost 70 or 80% of our patient presented either with positive lymph node or locally disease with parametrium infiltration, vaginal infiltration, or even infiltration to rectum. So the main line of treatment for this patient is a concurrent chemo radiotherapy with cisplatin. And as all we know, the overall treatment time shouldn't be exceed more than 8 weeks. But still we have some waiting on the radiotherapy machine. Sometimes the overall treatment time may be exceed up to 10 weeks, not only 7 weeks. And we actually use the conformal pelvic radiotherapy, external beam. We use four-fold technique with CT-based guided planning. But if the patient has positive para-aortic lymph node and we need to increase the dose, this is positive para-aortic lymph node, we use intensive modulated radiotherapy. But again, we don't have this type of the radiotherapy IMRT for all patients. We use only if the patient has positive para-aortic lymph node, because we need to increase the dose to para-aortic lymph node. As all we know, the IMRT associated with decreased toxicity, either acute or late GIT and genitourinary toxicity, besides the bone marrow sparing. So if the patient presented with locally advanced cervical cancer, this is our algorithm: receive external beam radiotherapy with concurrent cisplatin, followed by brachytherapy, and then patient carried on follow-up. We go to the important part of the treatment of the cancer cervix, which is the brachytherapy. The brachytherapy is putting this applicator inside the uterus to give high dose of radiation to remaining of the cervical tumor after external beam radiotherapy. And actually in Egypt, we have started with only one machine of the brachytherapy in 2018 in Alexandria, and now we have 6 machines of the brachytherapy all over the Egypt. We just go rapidly about how we can put this applicator inside the uterus. We may the patient will do this under general or spinal anesthesia. We put the patient in lithotomy position, then putting urinary catheter. After that, we make examination under the anesthesia, and this is very important for us to do how the residual tumor is present, either present only in cervix or vagina, or we have parametrium, and then we do serial dilatation of the cervical os using the Hager dilator, and after that, we use what is called uterine sound to assess the length of the uterus, and we can insert after that our tandem and ring. And sometimes we can use what is called interstitial needle if we have larger tumor residual reaching to the parametrium or even to the lower 1/3 of vagina. And after inserting this applicator, we use what is called modern brachytherapy technique. Let's just give a small brief about the brachytherapy. Before we had 2D brachytherapy. 2D brachytherapy, we prescribe the dose only to one point, which is called point A. And this, unfortunately, is not good representing of residual tumor. So we based on modern imaging technique or modern brachytherapy technique that they have 3D imaging using either CT or MRI. And we have the concept of the 4D imaging guided brachytherapy that we have GTV, high risk CTV, and we have what is called intermediate risk CTV. But all this based on GKS recommendations that use MRI, magnetic resonance imaging, at time of the brachytherapy. Putting the applicators, and the patient go to the room of MRI, doing imaging, and then we can come back to treatment planning machine to contour the GTV, which is residual tumor at time of brachytherapy, and then we contour what is called high risk CTV, is GTV plus any residual disease at the parametrium plus the cervix, and then we contour what is called intermediate risk CTV. And this image guided brachytherapy was in IMPRESS trial that I helped in this trial, and the result of the IMPRESS trial that is published in Lancet 2021 said that with using of MRI guided brachytherapy, we have very good local control, we have a very good morbidity after the image-guided radiotherapy. What is the problem in Africa and what is the problem in Egypt? The MRI is not present in the whole center of the radiotherapy, and actually it's not present beside the theater of our treatment. So we started to thinking about the CT-guided brachytherapy. I actually started working on CT-guided brachytherapy from 2012 and then 2015, starting just making a trial with my colleague in Vienna about the high-risk clinical target delineation in CT-guided cervical brachytherapy, using only information from Vigo staging with or without including the clinical examination. And the results of this trial found that inclusions of clinical examination is very important to improve our delineation. Then we go to the second step. What is the second step? And using the MRI before the brachytherapy. It's improve the contouring or not improving the contouring. And it was found that the using of MRI before the brachytherapy will help us to improve our contour on the CT guided, very important. And lastly, we published this in 2021 about the GKS recommendation for CT-based contouring in image-guided adaptive brachytherapy, and this was collaboration here from Egypt and from Vienna and from India with Umesh and from many people from the South America to get this recommendation. What this recommendation? This recommendation that is very important for you to have clinical examination documentation at time of the examination and the time of the diagnosis and the time of the brachytherapy, and also doing serial of clinical examination. And we have important of using the ultrasound during the application and using the MRI before the application. And we have many scenarios in this trial. You can access to this trial, and we will find appendix at end of this recommendation to see you, if, for example, if you have patients with stage 1B, what should be included and what we should be do. And this, for example, in CT guided, we have should be standardization of CT protocol using CT compatible applicator. We have rectal feeling, and also we have definition. We don't have GTV only in CT, but however, we have high risk CTV, and with this writing in detail in this paper, and also intermediate risk CTV. And this example, how we can make contouring based on the clinical remission at the time of the brachytherapy. Now, we have common language for treatment here in Egypt. That's all patients receive external beam radiotherapy concurrent with cisplatin, followed by the brachytherapy, CT-guided brachytherapy. Also, we have another abstract that was accepted at Astro. That's an stating of giving 7 gray in 4 fraction because we have a lot of patients and have a lot of risk. We use actually here 8 gray times 3. And actually we invited some people from Africa to train here in our center. And also we can adapt with some center in Kenya and in Nairobi that they can use only in the first fraction CT guided. And if the tumor is completely covered, we can use in the second and the third applicator only X-ray, because they have a lot of the patients with locally advanced cervical cancer. So our recommendation, external beam radiotherapy should be planned to use a newer technique of radiotherapy with concurrent-based chemotherapy. Brachytherapy remains the integral part. We go rapidly about the new adjuvant chemotherapy. Here in Egypt, again, we have accepted abstract in ESGO 2020 about using the new adjuvant in the cancer cervix. And we trialed this using carboplatin paclitaxel for 9 weeks. And what is our results? That we have the same local control, but the rate of the response, it become higher. We have a higher rate of response. And why we use new adjuvant here? Because we have a waiting list on the external beam machine, on the brachytherapy machine, to fill a gap, and to make this a gap for about 4 or 6 weeks, we gave the chemotherapy and then started immediate with the concurrent chemoradiotherapy. About the using of the immunotherapy in the cancer cervix is still new era, and not all the patient can use because of expensive and the cost of this immune. But as we know that the immunotherapy with concurrent radiotherapy, it improves the local control and improves the progression-free survival. And is a summary for the treatment of the cervical cancer from early and locally advanced. And thank you very much for your attention from my lovely country, Alexandria. Thank you.
Thank you, Nimat. Wow, Alexandria. We miss Alexandria and Egypt. So you call us during summertime, right?
Yeah,
Yes.
exactly.
Very historical
Any
place.
question for
Yeah.
Professor Nimat?
We suggest everybody should go there. And probably
Yeah, of course. We are waiting you.
Every January we are also coming to Cairo. Maybe you can make a joint visit also to Alexandria,
Inshallah, next time.
Mansoura. Every part of Egypt is really very nice. So thank you so much, Nimet. Really pleasure. Many of our attendees enjoyed your presentation.
Thank you very much.
And you also, Egypt is very rich actually compared to many African countries with respect to radiotherapy. As far as I know, you are number 1 in whole Africa. But anyhow, you still have some problems, the waiting times. See what exists in the other parts of the Africa. So it's always a problem. Maintenance is a problem. Manpower, technicians is a problem.
Yes, so
Brachytherapy
actually,
is a problem.
yes, we have a problem also in the source of the brachytherapy. So recent make what is called the replacement of all the iridium machine with a new cobalt machine, because as we know, the cobalt machine stay for us for 5 years and more, so we can maintain to treat our patient without breaking with the change of the source of the brachytherapy. We try to make adaptation to get our patients the best of our care.
Okay, so I think Reda, that is the end of the day. You also stay with me, Reda, and let's make a wrap up of today all together, right? Susanna, Reda, you are muted now. Susanna, do you have some slides prepared? Okay, the next slide, please. So, dear friends, first of all, I want to thank you, all of you. It was a hard day, the whole day meeting, and almost 200 people were always active with us, with 1,200 participants from more than 50 countries. I have learned a lot today from Rwanda, Ethiopia, and Ghana, Egypt. A lot of African countries were together with us tonight. And it's a beginning, and there are keynote messages for ESGO. We are here just to help you. But it's definitely we should move to resource-stratified prevention guidelines for low-middle income countries. A special thanks I give to Zana, but also three of our fellows from United Kingdom is the Laura, and then from Italy we have Nicolo, and also from Austria we have Nadia. They make a summary of the whole slides of today. So, and now we will just make a wrap up from these slides, and Reda and anybody can also join us and make comments on that. Hello to Indonesia also, from Turkey and from whole Europe and Africa. Vesna is with us. Mario is with us still, thanks to them. Nadia is still with us. So, Susanna, let's start wrap up of today. The summary slides. Can we move forward?
Yes, we are just waiting for the technician. He will do it immediately, Murat. If you can take
Ah,
a couple, there it is. Sorry for that.
okay. So today, one of the sessions was about vaccination, just blinded. What we discussed, there are a lot of new vaccines in the pipeline. There are a single dose strategies coming up. Plus, there are gender neutral vaccination possibilities for African countries, which we believe that it can be much faster. So let's see what are the summary slides. Okay, I am trying to move forward. Let me try again.
Just click in the presentation. Should be available for
Yeah,
you.
I am doing, but
Just a second.
okay.
Try again.
No. No.
Murat, try with mouse.
Is it
I'm-
working now? Who is making me?
Yeah. You might have been too fast.
Okay.
Would you go back?
So,
or-
okay. Can we go a little bit up? Yeah. There were some. Here we go, the summary. These are the new vaccines in the pipeline, in addition to Cervarix, Gardasil, and Gardasil 9. We have 6 more HPV vaccines in phase 2, phase 3 trials coming from China, India, Germany. Let's see. And of course, we have a lot of consideration. It's not only safety, the cost, but it's really very promising for the African countries that you will have cheaper products probably and with similar safety. And this is also nice presentation, nice slide of today, showing us that the coverage of HPV vaccination, starting of the vaccination programs is globally increasing a lot in the recent years. And especially the most high interest is coming now from Africa. It's really something that we need to congratulate everybody. Especially these are the new countries that bring the HPV vaccination very recently. Togo, Mali, Tunisia, Nigeria, Eswatini, Kiribati, Poland, Qatar, Kazakhstan. Thanks to all of them, Mongolia. What we also learned today is the Kenshi study. And this was a single dose study. And the follow-up is now actually 3 to 5 years. And they showed a similar HPV vaccine efficacy with single dose. The antibodies are high level and durable. Based on this non-inferior results, we can suggest a single dose as a start point for African countries, maybe with a poor foundation of vaccination. Another discussion of today was gender neutral vaccination, which is also important for actually Africa, because we have a high level of HIV, and HIV, increase the aggressiveness of HPV. So not only the ladies, but also to protect the males from HPV-related cancer. If you have start with a single dose, maybe the next step you can think about gender neutral vaccination. It's much more important, I have learned, today for Africa. Okay, this is the key messages for vaccination. Any comment on that? Otherwise, we can go to the screening session. Baklev, you are loading the screening session, right?
Yes, yes. Just a second.
Okay. 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 So this is about the screening. Thanks to all of our speakers. Screening is very, very important, especially for Africa again. Unfortunately, the similar rapid progress was not seen in Africa. Vaccine was very nice, but in screening, we are still lacking behind from many other countries. Okay. Okay. Of course, there are a lot of obstacles in those countries. It's not only lack of the manpower, but high cost for the screening. Problem with the screening versus vaccination. Fear of the ladies of gynecological examination, lack of awareness. There are a lot of problems, but these problems we concluded that was existing in all Western countries too. I mean, nothing should really prevent our screening efforts, these type of obstacles. For me, the main problem is actually the financial issues to cover the screening. One of the most commonly used screening method in Africa, especially Northeast Africa, is VIA. And today we learned a lot of information about VIA and VILI, the updated meta-analysis, showing a sensitivity similar to pap smear, but a lower specificity. VIA is something that you can start with. However, it's simple, it's sensitive, it's low cost, but still recommended by WHO. But once again, there will be, because of the low specificity, you will have probably much more over treatments with VIA. And sorry. And meanwhile, WHO has introduced much, suggest more, the more accurate tests, the HPV assays. But WHO here asks for clinically validated assays. And today we have around 500 types of HPV assays, but only clinical validated assays are suggested today to be used in screening. Of course, what we have learned today from screening is we can also make risk-based screening, which is you just screen with HPV with or without genotyping, but only for positive ladies. We can make AI visual AV, assisted visual evaluation, and categorize the ladies as high risk, intermediate risk, or normal risk. This is the paid study of NCI that's done in Africa. And the results are really very, very nice. So you just screen. If she's negative, you don't do anything. But if she's positive, then you can make a genotyping and you can make an AI assisted visual evaluation. This is a risk-based screening, and you can define high-risk ladies by this strategy. What we have learned in a lot of countries that you can use self-HPV kits also. But the acceptance is almost 97, 98% in African countries. And today we also heard about CarScan PCR kits, which you can easily find for less than $2 and including a self-test option. And of course, including the AVI, this cheap ESGO kits, PCR kits is another facility that you can start with pilot projects in your countries. Other than this, in the screening area, as you can see here, especially different African strategies. We heard about Democratic Congo, and we heard about Ghana, and we heard really pooling mechanism also for HPV DNA. They are all to decrease the costs of the screening. So what I can say, dear friends, for Africa, really the primary HPV DNA, with or without self-sampling issues, is not far away. So the prices, like as in the vaccines, seems that you can find simple, cost-effective, and cheap solutions. However, automated visual evaluation needs to be a part of the screening project if you are especially using primary healthcare staff to help them in colposcopy, biopsy, or ablation. Can we use directly colposcopy without any AI, without any genotyping? Yes, we heard about a recent meta-analysis of Mark Arbin showing that comparable and fair sensitivity and specificity. Again, you will have a little bit more over-treatment, but if your country does not have genotyping or AI facilities, it's also possible that you can directly refer your patient to colposcopy. Today, for some other countries, we heard about paper-based screening. This is E6 and E7 proteins. It's important. It shows more advanced level diseases. You can miss some low-grade CIN1 lesions, but definitely you will detect CIN3 and cancer lesions a lot. High negative predictive value, but again, very low sensitivity. So in some countries where you can only afford advanced level lesions, this is another approach, not to detect all lesions, but at least detect the high level lesions. Of course, cancer screening programs need some technical advice, and that's why NGOs, ESGO, and experts are here. It's not only making an HPV test, it's a registry issue, it's a follow-up issue. We are here to help you in all of these respects. For me, one of the big discussions of today, which is the best? As you can see, the world map via histology, HPV testing, especially in Africa, still via is number one. But in the world, HPV DNA is the best. For African countries, we really believe that if you can make cheap and somehow validated HPV kits, it is again the best option compared to VIA, compared to Pap smear, because of the very, very high sensitivity and self-sampling issues. So these are the take-home messages for cervical cancer screening. Basically, either HPV DNA or VIA or paper-based E6, E7, depending on your country's situation. Plus, self-sampling issues are important. AI can be implemented for a successful program, but the most important point is think about your economy and your budget, and a low-cost cancer screening test is the best as a start point. So can we go to the next summary of the session 3, I think, colposcopy? Yeah. After screening, as I told you, what we have learned via, or then you can use HPV or E6, E7 paper test, but the patient needs a colposcopy, and there are some challenges. Resna today clearly declared this. Okay, we need some faster pathways for Africa, and therefore we really go to the village, use a very high sensitive test, and find the really definitely accurately highest risk patients. Therefore, today's discussion showed us that the HPV DNA test is again best option for Africa, because you go to a rural area and you want to take all high-risk patients as much as possible. Once you make an HPV result, then you can look to the genotypes, you can make a visual evaluation with AVI, and then decide to follow up or treatment. One discussion: to excite or ablate, which one is the best? As we thought, both are acceptable success rates, depending on the lesion, depending on the transformation zone, depending on the glandular involvement. You can prefer either excisional or ablational treatments. But this was the main conclusion of the colposcopy session. An HPV test, low cost, scalable, reliable tests are the main topic of colposcopy. Of course, the great question came for training. The best model is train the trainers model, which means that we will have local colposcopy leaders in Africa, and these leaders will teach the others. Thanks to ESGO in this respect, because we very soon will start these colposcopy European trainings in our webpage. We see several good examples today from Tanzania. This is a colposcopy course, talking the basics, screening, the minor and major changes. Again, in Tanzania, different types of speakers, including the society leaders, the management part. These are all important issues of the trainings. In this respect, the promising one is that issue is that the AI is, can I go previous slide? Okay. Anyhow, we heard about the, yes. 1 minute. Yes. In this respect, we talk about the PAVE study, the smart cell phone study. It's very easy, cheap, and usable in Africa, as I told you, self-sampling HPV. And then for the high risks, especially, you make an image, you send to the web, and then the cell phone, the smartphone, gives you either the patient is low or high risk for CIN3. And if they are high risk, then you can make immediately thermal ablation on site. This is the fastest treatment option. You see this smartphone, portable, easy, inexpensive. So once you have a nice HPV test with genotyping, I think the best solution for the nurses, for the midwives, for the health technicians is to use this smartphone program showing how much high-grade lesion are these, to biopsy, to ablate, or to excise in a hospital-based setting. Okay, so one of the important parts of this today's is that please, when you go to these rural areas far away from the home, there is vulvar inspection possibility. It's not only cervical cancer, but open your eyes that you can at the same time make some sorts of vulvar examination. And this is something that in the long term, we should also follow up. So basically, high precision tests to detect risk populations, less specimens, more technology, and focus on education and training. Okay, what is the last session? summary of the last session about the treatment, I think. Susanna, do we have?
Coming up. It is coming up.
Coming up. Okay. So this is session 5, last session, treatment session. We were all proud of what ESGO has done about the resource-stratified guidelines, because ESGO has important guidelines, but in real life they were not working, because you don't have radiotherapy, you don't have radiological infrastructure. But now we have at least a background document from ESGO where in your low resource countries you can use. David Cibula has given several examples from these guidelines. You can easily download from the ESGO webpage, of course. If you don't have an MRI, you can use ultrasonography. And then another one example, I think, was about expert limitations. You don't have, you have the experts now. You have the ESGO behind you. But anyhow, if you don't have ultrasound experts, then you have the chance to get trained in ESGO ultrasonography courses, ECO ultrasonography courses. Another one is, for example, sentinel lymph node. You cannot make, you don't have the pathologist, or you don't have the ICG. But still, we have a very, very cheap dye, blue dye, that you can use to target the highest lymph nodes, to map them, and to just dissect these 1 or 2 methylene blue positive lymph nodes. And it is the easiest way to teach your local surgeons how to make a lymphadenectomy in these 1 or 2 lymph nodes. Regarding the ultra staging, once again, we discussed that rather than looking 30, 40, 50 lymph nodes one by one, it's better to look to 1 or 2 lymph nodes and make multi-slicing ultra staging of these lymph nodes. It's because it's the only way, the highest sensitivity to detect the lymph node metastasis. So of course you will first teach one pathologist, and day by day you will increase the number of the pathologists. Today, among the treatment of the pre-invasive diseases, we listened a wonderful lecture from Maria Kyrgiou. For your highly asked questions, once again, if you can make an ablation in the selected patients, you can see here on the slide. But once again, if it's a type 3 transformation zone, if you have a invasive disease suspicion, or if you have endocervical canal or glandular lesion, then it's better to prefer the excisional treatments. The margins is very, very important. The recurrence rate after your ablation or your excisional treatment directly depends on the value of the margins. So if the second point is if the patient is still HPV positive or negative, so after your treatment, the prognosis of the patient depends if the margins are negative or if she became HPV negative. Mara Kyrgiou also underlined the fact that there are different types of treatments. The most balanced one is LEAP, both excisional treatments. And then you can, it's really balanced between the treatment failure versus preterm birth. Cold life conization, especially for nulliparous patients, is important. You have to prevent the preterm birth. So therefore, the blue one, LEAP, is one of the best balance. But you should always question the type of the patient, age of the patient, how many child they have, these type of complications. But it's definitely that the best treatment comes from cold conization with high risk of preterm birth. And ablative treatment is also balanced, but still is safe for the preterm birth, but still have 16 to 15% treatment failure. And that's how we discussed here. As you can see, with limited patients numbers, you can use thermal ablation. And it's also approved by WHO guidelines. We also listened a very nice new LEAP, modified LEAP video. It really can decrease the relative high cost. So you can use in your countries this new modified LEAP technique. Actually, we also talk about the invasive cancer treatment, and we learned that for MRI and for chemoradiotherapy, there are a lot of options in Cairo, but still lacking. In general, Africa, we have a lot of problems. So this was the end of today, my dear friends. Do you have any other questions? Regards your notes. Maybe in the remaining time, I cannot open my camera, but I don't know how. This is not my screen. Zanla, if you can open my camera somehow, I don't know.
Camera is open, Murad. It's just the view that is different. So we will close the screen very soon. Thank you,
Okay.
technicians.
So who is still with us? You can open your camera and just say a goodbye to everybody. Hi, Lala. Oh, Gabriel. Nice to see you. Mario is with us. Meanwhile, Javier Bosch has sent a message. He has a wonderful World HPV World Journal. If you have any story in your African countries, you can share with Javier Bosch to publish it in HPV World Journal. Didem, nice to see you once again. Andrea. So, Zuzana, take a picture of us for Africa. Next year, please make your masks. We will be all African, okay?
Okay.
Thank you so much, Mario, for all you did.
Okay, thank
It
you.
was nice to hear from you that there is no need for validation. Okay, dears. Thank you so much. See you.
Thank you,
next
Thank
year.
you, Susanna. Thank you for all.
Thank you, everyone.
Thank you.
If you want to
Excellent.
be a speaker in January Cairo meeting, let Susanna to know. Okay?
Okay.
Thank you.
Yes.
Bye.
Thank you.
Bye
Thank you
bye.
very
Bye.
much.
Thank you all.
Bye-bye.
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 Bye-bye. Bye.
See you.
Bye bye.
Bye-bye.
Bye.
Bye. Mario, bye.
Bye.
Bye bye.
Bye.
Здраво.
Bye.
До
It was nice
widzenia.
to see
До
you.
widzenia.
Virginia.
До widzenia.
Ciao.
Здраво, здраво.
Bye.
Bye.